Thank you so much for the introduction. Hello, everyone. I'll be presenting on service delivering models for people who inject drugs in North America. The objectives for my presentation are defining harm reduction, understanding salient features for successful care delivery, identifying available treatment modalities associated with successful care delivery, and then integrating COVID-19 precautions into existing care systems. So first, I want to start by defining harm reduction. Hawk and colleagues trace the concept back to the early 1900s, but most recently it rose to prominence in the 1970s and 80s in response to infectious disease as a result of problematic substance use. It's defined in that article as reducing the negative effects of health behaviors without necessarily extinguishing the problematic health behaviors completely or permanently. However, I think we should think bigger. The Harm Reduction Coalition defines harm reduction as a philosophical and political movement focused on shifting power and resources from the most vulnerable to structural violence. This approach has fundamental beliefs in how to provide the services, and risk reduction are the tools and services to reduce potential harm. The Harm Reduction Coalition has many tenets and principles of successful care delivery and harm reduction for people who inject drugs. The three most salient, I believe, are that people who inject drugs and those in recovery should have a real voice in the creation of programs and policies designed to serve them. We must also recognize that drug use is complex and on a continuum of behaviors from severe to total abstinence, and that there are some ways of using that are clearly safer than others. And then finally, the most important tenet of service delivery is that we provide non-judgmental and non-coercive services and resources to people who inject drugs and the communities in which they live. So some features of successful care delivery. I've done a recent literature review, and some of the structural characteristics associated with successful care delivery and healthcare engagement for people who inject drugs start in structural characteristics or enabling characteristics. Health insurance and financial barriers being the first. Health insurance and having health insurance has been associated with increases in primary care visits and increases in antiretroviral uptake. Conversely, increases in financial barriers have been associated with lack of access to a primary care provider or having an established primary care. Co-location of services have been shown to prove high retention in HIV and hepatitis C care when co-located with medication for opioid use disorder, so that being buprenorphine or methadone. Models of care connection and low barrier treatment at syringe exchange have also shown to be promising. And I'll talk about a few of those later in my slides. And then finally, the patient-provider relationship, having a positive relationship with your patients has been associated strongly with healthcare engagement for people who inject drugs. Some need-based characteristics that are often understudied. Data from the AIDS-linked intravenous experience cohort has shown a high prevalence of non-communicable chronic diseases for people who inject drugs. So this includes hypertension, diabetes, obstructive pulmonary disease, and anemia. We often think of care delivery for people who inject drugs as mitigating the risks associated with injection drug use, as well as prevention of infectious disease. But these non-communicable diseases, according to the live data, were underdiagnosed and diagnosed in later stages of disease. So we must start thinking about our patients as holistic patients and consumers of healthcare, integrating holistic and high quality primary care services with harm reduction and mitigating the consequences of infectious diseases all together in a co-located location are probably the gold standard for delivering the best quality care for this population. And then finally, some health behaviors. Injecting in the last 6 months has been associated with lapses in HIV care and virologic failure. It's also been associated with being intermittently or virally suppressed. And then finally, worse linkage or retention in care. That's to say that increased amounts of injection have been associated with this, but conversely, those engaged in harm reduction services, one study found that individuals who were exchanging more needles were actually more likely to be engaged with their primary care provider. So delivering high high quality care should not be associated with whether or not your individual is actively injecting, but rather in response to and even better services if if active engagement is ongoing. So some treatment modalities I want to talk about. First, I want to discuss low barrier care. While commonly discussed in the literature with respect to medication for opioid use disorder, i.e. Suboxone, buprenorphine, or methadone, low barrier care can be a tenet of successful care delivery for people who inject drugs. An alternate approach to describe the removal of as many treatment barriers as possible. It is on demand, it is flexible, and it's destigmatizing. One example of low threshold or low barrier care is the Project Connections at Reentry, PCARE. This was designed to address gaps in coverage for justice-involved individuals. The team found that there was a risk of overdose following, there was a high risk of overdose following incarceration. There were adverse consequences with opioid use that were heightened for this population, and that opioid use disorder remains under or untreated in corrections facilities. They established a low threshold van outside of the jail, which engages patients who were referred by jail staff or were walk-in and self-referred. They had a care team of a primary care provider, a nurse, and a peer recovery coach who stabilized the patient and referred them to long-term treatment programs or primary care provider for buprenorphine management. They were able to do induction for Suboxone the same day and follow up with them for a period of time until they were able to get them to a more sustainable source of their medication for opioid use disorder. And this is probably one of the gold standards of providing care where it's necessary and where it needs to be in a low threshold manner. I want to take a moment to discuss that so far I have focused on literature and programs that have been in the United States and Canada, but since this is a talk about North America, this is data from Mexico where Cepeda and colleagues really identified policy and programs that were the gold standards for treating people who inject drugs. And some of the tenets of these programs were very similar to what I've been discussing so far. They include the provision of high quality and accessible and affordable opioid antagonist treatment, ensuring high coverage for HIV antiretroviral therapy, scaling up harm reduction services, and ensuring that drug treatment programs are evidence-based and non-compulsory when it comes to abstinence-only programs. So really taking all the best information, co-locating it in one location as best as possible, and making treatment as accessible for this population is the best way to provide services. So I want to take a quick moment to discuss COVID-19. And state that partnerships are key, especially as we're moving into a phase of vaccination, but we're still thinking about mitigating the harms of COVID-19. What we've done in Baltimore City is combine COVID-19 vaccination with the Baltimore City Health Department's Syringe Support Services program. These are 2 mobile vans that we've parked in the community to provide syringes, COVID-19 vaccination, point of care HIV and STI testing, ad hoc wound care, and then care navigation. What we've done is clients of the Syringe Support Services program visit for their needles, and then they're referred to our clinic for COVID-19 vaccination. The staff at their facility talk to them about the vaccine, and then they have an opportunity to talk to us about the vaccine. We've offered both 2-dose and 1-dose vaccination, and have had uptake of both with good success. We've had high uptake of HIV and STI testing as well, and for a few individuals, we were able to do wound care at site, and then for those who tested positive for HIV or STIs, as well as those with increased care needs when it came to their wound care, we were able to make sure they had navigation to a long-term primary care provider. The most important tenet of this, though, is that the SSP, the Syringe Support Services program, has had high trust in the community, and having the referral from them made this partnership really key in ensuring that we provide high-quality COVID-19 vaccination to this population which might have been previously ignored. So some final thoughts for care providers. Applying a harm reduction framework to your healthcare delivery is key. Integrating services in one location makes care flexible and practical for this population. And then a low barrier mindset when delivering care services ensures that you provide care to meet the needs of your population. And then finally, I do want to make this note that for all care providers, naloxone prescription and education is a must for every single patient. It's for any individual with ongoing substance use, regardless of if it's an opioid, or if individuals know someone who uses drugs, or anytime you give a prescription for opioids. It is just a common good practice for a very low cost prescription, which can have high benefit in the future. And then finally, I want to state that we really need to just meet our patients where they're at in their care. Care is a continuum, and we need to ensure that we're meeting the needs of individuals at the time when they need it in the best high quality manner possible. I want to take a moment to acknowledge my funding, the T32 Drug Dependence Epidemiology Program. And here are my references. Thank you so much.